Well, we're back to Genesis. Well, I don't know what your session was like, but ours was fantastic. I personally learned the most today that I've learned in the last 45 minutes. It's really made me see the question of healthcare design and delivery and what we mean by that. So, thank you for that. Great. So, healthcare design, healthcare delivery. Is it possible to narrow the gap between the real and the ideal in healthcare design and delivery? What do we mean by that? What examples can we point to of existing best practice? Are these best practices possibly creating their own hegemony, which is stifling innovation, or some of the things that we were talking about? And I'm really excited to hear what the other groups have been talking about, so may I invite Group 1 to the board?
Go on. People are bored of my music.
Here we go. Got what I said now. We did sum up this session. There is another poster over here. I don't know the feed is getting. Is the feed getting that poster?
I'll post it up.
Just a minute, it's going to be posted up. So we started thinking about design of what things that we liked, first of all, the sort of ideas things. So these were things like Mayo Clinic, what's happening in Taiwan. We also went outside health and started to think about things like Toyota. I'm going to skip some of the conversations about how we got there, but I think where we finished up, and then we'll work backwards, was that it needs to be patient-centric. Now, we all say that, don't we? But what did we mean? It really summed it up when somebody who was talking about being a type 1 diabetic, about what are the incentives, what's in it for me about a design of a system. And the incentives there were as simple as having a graph of your A1C level. So that would have been great. The next level on from there is, how do I then motivate? That's the next bit of, how do I keep control? And clearly then we went on to other things about incentives. We started sort of going on about goals, gamification, rewards, badges. I know a lot has been talked about that in social media, etc. But again, in terms of design, we've got to think of those human aspects that keep people engaged and keep going about something. And then this was a little sticky conversation here about in partnership, about who's going to fund this, what does the model look like, how long term is it, what risks have we got, who's in that group that are going to develop this, run it, keep it there. Is it a one-year campaign or is it a long-term campaign? Is it added to your product? Is it added to your service? Lots of sort of, I don't think we resolved those, did we? They were all sort of like those tweets that sort of people just throw out there. So there we go. I guess one of the things that again came out was this aspect of how are we managing failure. So we're going to develop these systems and we've just got to know that we're in the classic sort of, we're always going to be in beta about developing this, because there will be a lot of things and there will be a lot of things that we think are great but the patients think are not great. So how do we move on from there? We talked a lot, again we got into a little sort of narrative about privacy, consistency, etc., which again in terms of designs we've got to capture right now of where that is, but again we were thinking maybe does that move? Do the social, just general norms about privacy move on, or do they stick? And that's where we got to there. Again, I think one of the other aspects on this other board about thick or thin value, which comes from a guy called Yume Haig, we're describing there about, are we just looking for efficiencies in the system that we're designing, as in thin value, just sort of making it cheaper or that type of thing, or are we looking at thick value, something that's really going to change? It's a game changer. It may also involve things like the ecological aspect of the environmental aspect of the product or service that somebody's delivering. So, you know, that type of thing was brought in. Again, you know, sort of things like these rewards, again, you know, looking at other stakeholders for clinicians, etc. And I'm now, that's where I stopped listening, but I'm wondering if there's anything else there from... No.
thank you very much, Mike, for that jog through entering states of perception. I'm sure there was something in those tumour apps. I'm feeling quite lightheaded. So for the second group, can I invite somebody, Alison and Miles, to come up and present?
We sort of had, I guess it isn't a problem, we had a similar issue to you, Mike, where things were just being thrown out and it sort of didn't really structure itself. How can I say this?
There was some, yeah, those magnetic things. Magno sticker.
So I mean, we started trying to find what we felt was real and happening right now, and how we could try and get that to be ideal. We felt the real was the paternalistic approach, focus on logistics. And we had a focus in our group on sort of NHS and English problems, which was probably due to the fact that none of us were English. And so we came across, in terms of examples that we wanted to replicate in the real world, is sort of Mayo Clinic, Ragu, like we said before. And then Dignitas came up, even though it's not digital, it's the idea of having an end point, having a service that is brought about through patient need, not through necessarily what is thought is right and what is thought is wrong. And Andrew wrote this. Designers aren't trained to measure, which meant
I wrote it, or didn't think it. I didn't say it. This was Alison.
This is because designers are not trained to measure, and if anything's going to be successful in the NHS or the real world, actually, you need to know that it works. And the only way to do that is to measure it, to count it. How many people enjoy it? Does it work? And it's not just the designer turning up with their spiky shoes and saying, "Do you like it? Does it work? Tell me how great it is." It's actually testing it over time. And because of real life projects, that's what happens. Because funding stops, designers move on to the next project, and it just doesn't happen like that. So designers aren't trained to measure. So if the designers come into healthcare and they don't understand that, then that's a massive problem. And it's actually quite an interesting area, because I'm in at the moment, to actually learn how to measure, work with statisticians, etc., and develop measurement which can be creative and can invite people into the process.
And we thought, we talked a lot about the how would you get to the real, from the real, to the ideal. And we sort of felt that sometimes you have to have that out of box, not necessarily out of box thinking, but out of the situation. So often you get sort of healthcare innovation happening within healthcare, and sometimes you need to think away, and we brought up examples of Virgin Atlantic and things like that, sort of ways that private industry can adapt to what its customers want in the way that healthcare just doesn't at the moment. Sometimes it does, but most of the time there isn't a sort of a loop that the patient wants something so it happens. It's quite often what happens already and how do we change that. We came up with this sort of Kaiser Permanente sort of example of the majority of people can self-medicate, self-regulate what they're doing. And actually the access should be reserved to the people who are at the top and can't. And maybe digital can really come in here at the bottom and work for the majority to lessen their time with the doctors and things like that.
And also in this diagram, so it basically shows the population, and then there's the tiny slice at the top that hospitals actually cater for. Therefore, that means that people with chronic illnesses and generally everybody else that is not the definition of healthy cannot go to a hospital for care. Therefore, where else can we get the care? And this then challenges us to redefine what it means to be healthy and to redefine what care is, and therefore what all the touch points of that are.
And another ideal situation we had was, I think it was John who brought up the idea of going to the hospital being something that has become an event or become sort of what you do, whereas actually maybe the idea is that this healthcare comes to you. And we gave the example of the iPhone being such a powerful tool that if we use that more, then healthcare could come to us rather than needing the patient to go to the hospital. This is sort of a summary type stuff. Some of the answers, as in the real, does exist, but so often the problem comes in how to implement them. How do we get these great ideas, these innovations, and shake it up, especially in the NHS, where that is very difficult. It is necessary to innovate things from this, but it's about getting the right innovation and how we do that. And sometimes that is counting, it is statistics. And then the sort of tagline we came up with, to sum it all up, was take the real and make it more ideal. And that's where we got to.
So I need to add a terms and conditions there, and that's like, we weren't saying that buying an airline ticket is like going to see a specialist, right? But we know we can do it. But that's a fantastic summary of the conversation which we had, which, as I say, totally decentered the way that I've looked at some of these issues. So thanks in particular to for expressing that so eloquently. So, final group 3. Who's up?